always say that we have one of the finest person in echocardiography who practice echocardiography in his clinical practice. That's what he's a director of heart failure program at Medanta Medicity. And what is heart failure? Heart failure is nothing systolic and diastolic function, looking at the RV, RA systolic pressures, looking at an IVC. And that's what the jumble game of a heart failure is. So I would like Dr. Sanjay Mittal, sir, to start his
Thank you,
excellent
boss, as ever.
presentation. And I'm always fine, Dr. Sanjay. And I always proud to say this 49th course has this 49th lecture in this particular echocardiography. So we are there since the day one, when he was young and I too was young, 25 years down the line. So that's what it is. And is amazing talk. When he talks of a systolic function, believe my words, is really an amazing talk. He tries to explain each and everything how to look for a systolic. Thank you, Sanjay. It's all yours.
Yeah,
You can start your proceeding. I'll stop sharing the slide. Please go ahead and share your slides.
yeah. Thank you, Dr. Rakesh. I think, as ever, I'm enamored by what you say about me. I do not know whether I'm worth it or not, but well, we'll know. We'll come to know whether it is of any use speaking like that about me.
You know
So,
what
good
exactly
evening.
happened, Dr. Sanjay? When the people they send back your feedback, I'll transfer all those feedback to you.
Oh, thank you. But let's go on with the important thing of left ventricular systolic function evaluation. I'm going to be focusing on the left ventricle, and I'm going to be focusing on the systolic function evaluation because, as Dr. Rakesh Gupta very clearly mentioned, for heart failure, the symptoms actually correlate with the diastolic function more than the systolic function. But the commonest reason for us evaluating the heart failure population is to evaluate for the systolic dysfunction. Why? Because most of the treatments available today are to target to the population who have systolic dysfunction in presence of heart failure rather than the diastolic dysfunction, because there are treatments, at least 4 or 5 mainline treatments available for them. So I was understanding and probably listening to a couple of questions which some of you guys raised while I was just blindly watching. Is that you had a difficulty in focusing tricuspid valve or mitral valve and all. You can imagine your ecstasy, but you can also imagine what Edler's ecstasy was when he first saw the mitral valve tip on the B mode or A mode of ultrasonography when it was first discovered. So I would like to say that what you read in books or what you see on the screen mentioned to you by the stalwarts is something, as very rightly put by Dr. Rakesh, after the experience of years, months, not months, years, and decades of putting the probe, understanding what the heart image is, and how to rotate and how to move our hands and fingers and probes in order to optimize the images. It's just like reading how to ride a bicycle in books and actually learning how to ride it. So you would have to falter. You have to actually make errors, but you have to correct yourself. You have the theoretical knowledge, that's at the back burner, but you have to actually make errors and the judgment of your errors and improve on them. Sorry, my throat is back. So that is something which is so very important. Nothing can be built up by just watching on a good lecture or reading through a good book or 2 books or 2 books, 3 books or whatever. You have to use your judgment, use your probe, use your imagination, optimize those imaginations into your feedbacks, and then only you'll improve your functions. Well, let's move on to my lecture, otherwise we'll keep on talking. Um, the the things which I'm going to discuss today are going to be basics, the conceptual basics, which are so very important. You know, if you have the concepts right, you can utilize them in your clinics. One, I am going to talk to you about the regional wall motion abnormalities. Second is the global left ventricular functions. And I'm going to also touch base on an aspect of tissue Doppler imaging and strain while I'm going to go ahead with the talk. So when we assess the left ventricular systolic functions, we have to categorize them into two parts. The first important one is the region. The left ventricle is like a bullet, as they always mentioned, and there are various segments of this left ventricle, and not necessarily each segment would be dysfunctional or not contracting as well as the rest of the segments would be. I give you this cartoon. If there is a lesion in the front artery, this is the left anterior descending artery, it would lead to the blockage of flow into the area distal to the blockage. And this would lead to ischemic cascade. Ischemic cascade is as soon as the blockage happens, the flow is the first thing to come down. Thereafter, there would be some metabolic alterations. The diastolic dysfunction would alter. That means the relaxation properties of the muscle at that particular area would get impacted first. And then we get this synergy, or we can call as systolic dysfunction, which would ensue after the diastolic function ensues. The symptoms of angina actually ensue much later. And that is why the echocardiography picks up wall motion abnormalities much earlier than the symptoms of ischemia arise. Important aspect about this thing also is to understand that because diastolic functions are more general, there's no definitive regional diastolic dysfunction. That is why, unfortunately, diastolic dysfunctions are not very dogmatically diagnostic of ischemia. The ischemia is basically diagnosed on the basis of presence or absence of wall motion abnormalities. Okay, let me see here. Let us see what I'm trying to show here. This is a four-chamber view of the echocardiogram, where this is the mitral valve. You can see here the tricuspid valve, left atrium, right ventricle, and the left ventricle. If you can imagine, the portion of the left ventricle closer to the mitral valve, which we call as basal segments, are contracting pretty well. You can see them coming in, thickening, and everything. But if you look at the area towards the apex, the tip of the ventricle, you can see this is not moving in at all, and there is hardly any thickening. So this is what we call as some segments of the ventricle not contracting, whereas the rest of the segments contracting pretty well. And we rank this as segmental. Segmental. These segments, wall motion abnormalities. And whenever we find segmental wall motion abnormalities when we do an echocardiogram, that means some segments not contracting as well as the rest of the segments, we call this as almost certain diagnostic criteria for infarction or ischemia related to coronary maldistribution of blood supply. However, there could be certain circumstances when you can have a patching myocarditis. We can have certain areas not contracting as well as the rest of them, but then they do not obey the distribution pattern of a coronary artery. So this is very important. And as we understand, almost 70% of the burden of all us cardiologists is because of coronary artery disease. We have to be assured and ascertaining ourselves to be able to understand and analyze wall motion abnormalities very clearly. So let's discuss a little bit more about it. What are the mechanisms and what are the concepts? There are various mechanisms that the whole of the left ventricle bullet, like this, is divided into various segments. And this is basically on an amount of equal proportion of the heart muscle which is there. However, we have 16 segment, 17 and 18 segment scoring models. But the common one is the 16 segment scoring model, which we use for echocardiogram conventionally. The 18 segments are basically the computerized segment scoring system, which we use for speckle tracking. And most of the perfusion imaging studies use the 17 segment scoring system, which is in the form of thallium scans and all, which use the 17 segment scoring system. Where is the difference? The difference lies because the apex, the tip of the apex is ranked as the 17 segments. Rest of the compounds are the same. That means there is going to be basal level, 6 segments, 1, 2, 3, 4, 5, 6. There's going to be mid-level segments, 7, 8, 9, 10, 11, and 12. And the apex is divided into 4 segments only, 13, 14, 15, and 16. How do we do that? We have two landmarks here. One is the insertion point of the right ventricle anteriorly and the posteriorly. You can see this right ventricular free wall, and this is what is the landmark. Wherever it is here, this is the anterior interventricular groove, right? This is the right ventricle, this is the left ventricular wall, and this is the anterior interventricular groove, and the same thing is the posterior interventricular groove. This defines very important landmarks. Let me go ahead further. So as I was trying to analyze and explain to you, the anterior interventricular groove is the position when we rank this as a cutoff point for the right ventricular insertion point. Anything beyond the lateral side is the anterior wall. The medial side towards the septum would be anterior septum. So anterior wall and anterior septum. This is why it is written ASP. The lateral portion would be lateral wall, furthermore would be posterior wall, furthermore would be inferior wall, and this portion would be the septum, which is the posterior component of the septum, and that is why we use that septum. And I'll tell you why we don't call it posterior septum, we just call it septum. So when we are doing the customary views, the parasternal long axis view, the chest is where we put the transducer oriented towards the long axis of the heart. So if we put the transducer through the long axis of the heart, we cut through the anterior portion of the right ventricle, we call as right ventricular outflow tract area. We cut through the anterior septum and we cut through the posterior wall. And look at these two papillary muscles. They are not in the posterior wall, inferior wall as well as lateral wall. So when we look at the representation of parasternal long axis view, we'll have the first representation of the right ventricular RVOT, the right ventricular free wall here, right ventricular outflow tract. If you can follow my cursor here, there would be
Understood.
anterior septum
Eh?
here. Hello,
Uh, so,
Dr. Anil Chaudhary, the voice is not muted. Please
sorry,
voice
sorry, sir, sorry.
mute yourself, please. Okay. And thereafter, as the transducer go through the left ventricular cavity, this would be the posterior wall. Then what we do is from the parasternal view, we put the transducer towards the apex. So when we move towards the apex, we cut the transducer, the left ventricle, into a longitudinal fashion, where the right ventricular free wall is going to be there. If we look at this four-chamber view, this is the right ventricular free wall. Then there would be the septal portion, which is, as I said, the posterior component of the septum, and the lateral wall, which is the muscle, the papillary muscle head, which is seen here. Unfortunately, the quality of image is not so good, but the papillary muscle origin is here, which we call as the anterolateral papillary muscle. And when we rotate the transducer furthermore to about 60 degrees, and we lose the complete right ventricle, so there is no right ventricular component anywhere, we find the inferior wall and the anterior wall of the left ventricle, which is seen in this particular view. So if we look at the three bread and butter views, the parasternal long axis view looks at the anterior septum and the posterior wall of the left ventricle. The four chamber view looks at the septum and the lateral wall and the inferior wall and the anterior wall of the left ventricle in the two chamber view. So this is what is important description. Now, let's see how this description of these segments are divided into the basal, mid, and apical views. The whole length of the segments in the long axis views is divided into three parts: the basal portion, the mid portion, and the apical portion. And these are equal thirds. Mid portion gives rise to the papillary muscles, right? So as I said, the four chamber view would give rise to anterolateral papillary muscle in the mid portion. Any area beyond that would be apical view, and before that would the basal view. The other thing is the two chamber view. Again, the inferior wall mid portion gives rise to the posterior inferior papillary muscle. There would be apical inferior and apicobasal the same way. The apical inferior wall, basal inferior wall, and the anterior wall are divided into the same proportion. Now, how do you importantly correlate with the coronary artery distribution? You have to understand the anatomy a little better. Okay, for that particular sake, as I described, what is the course of the left anterior descending artery? Left anterior descending artery runs in the anterior interventricular groove, right? Why? Because as soon as it originates from the base, it runs all the way down to the length of the left ventricle and winds around the apex. Why? Because LAD is supposedly most oftenly the longest artery and supplies all the areas adjacent to that. So if it is running in the anterior interventricular groove, it would supply medial and the lateral portion. That means the anterior wall and the anterior septum all the way through the course of the length of the left anterior descending artery. But as it is winding down the apex, most often, more than 60% of times, all these segments, the apical inferior, apical anterior, apical lateral, and apical septum also is supplied by the LAD. So it's a very simple thing. LED supplies all the segments in accordance to wherever it is flowing. The anterior wall in totality, as you see here, all that dotted line is anterior wall. The apex, all the four segments of the apex are supplied by the LED and also the anterior septum, basal anterior and mid anterior septum. Mind it, because parasternal long axis view does not go to the apex, that is why you do not have an apical anterior septal area. It is only basal anterior septum and mid anterior septum. And this is the reason why we do not use the posterior septum, because at the apex, there is only one segment in the septal area, which is called a septum, apical septum. There is no apical anterior septum. And that is the reason to eliminate the confusion wherever we have apical septum, mid septum, and basal septum. So if you look at four-chamber view, we would have apical representation of the LAD. The lateral wall is not supplied by the LAD commonly, and this septal area is not supplied by the LAD. It is only the apical septum and apical lateral commonly supplied by the LAD. In the two-chamber view, the whole length of the anterior wall and the apical and inferior wall is supplied by the LAD, and the basal anterior septum and mid anterior septum, which amounts for almost 8 segments out of 16 supplied by the LAD, almost 50% of the myocardium. 1, 2, 3, 4, 5, 6, 7, and 8. 8 segments out of the total of possible 16 segments are supplied by the LAD. So this is a simple way. The other thing is, because the proximal LAD is here, so the proximal diagonal is going to be supplied at this particular level, and proximal septal is going to be supplying at this level, you can somehow how also diagnose whether the LAD lesion is proximal or distal, and give you examples when I go further. Let's talk about circumflex. As you all know, circumflex is an artery, runs in the atrioventricular groove on the left side, right? From the anterior side, it winds round the left ventricle and goes to the posterior wall. Most commonly ends before the posterior interventricular groove, but sometimes it goes up to that and supplies the PDA. Most oftenly, it does not. So obviously, it would supply all the areas in adjacent to that. So the lateral wall and the posterior wall, the mid and basal and mid portion is supplied by the circumflex. The basal and mid portion of the lateral wall and basal and mid portion of the posterior wall is supplied by the LCX. The posterior descending artery is running in the posterior interventricular groove and commonly arising from the right coronary artery and would supply areas adjacent to that. So this supplies mid and basal septum and mid and basal inferior wall. Mind it, there would always be a gray zone, penumbra zones where there would be overlap of the coronary circulation. So this area, for example, this area would be supplied possibly by both the arteries. Commonly, mid septum and basal septum is supplied by the PDA, and the mid inferior and the basal inferior supplied by posterior left ventricular branches of the right coronary artery. Sometimes as much as 40% of times when the right coronary artery is non-dominant, circumflex takes over these territories of supply. But as of now, we have to understand whenever the right coronary is dominant, these are the territories supplied by those arteries. Many a times we can do a superimposition of those segments. As I said, this is the mitral valve. You can see the mitral valve opened here, and the whole circumference of this segments is the short axis at the basal level. So mitral valve, when we are seeing the mitral valve tip, we are talking about the basal segments of the left ventricle. And if we look at the insertion point of the right ventricle from here to here, this would be anterior septum, this would be septum, this would be inferior, posterior, lateral, and anterior wall. Then would be these segments when we have the papillary muscle, posterior inferior papillary muscle, and anterolateral papillary muscle. Here again, there would be anterior septum, septum, inferior wall, posterior wall, lateral wall, and anterior wall. So all those are equally distant segments. And this is the apex, where we just have four segments: the septal area, the inferior area, the lateral area, and the anterior area. So those are the four segments at the apex. And if we can superimpose these circles, one, two, three, we can draw a bullseye. So this is the basal segment from here. This is middle ring is the mid segments, and the apical ring is the apical segments. We have the four segments. The LAD is running in the anterior interventricular groove from the base to the apex, winding around the apex and supplying all the areas around it, the diagonals and the septal branches, the first diagonal, the first septal, the second diagonal, second septal, and like that. The circumflex runs in the posterior interventricular atrioventricular groove, supplying the OMs, the first OM, supplying the lateral wall, the second OM, and the third OM if it ever. The RCA supplying the PDA, posterior descending artery, and the posterior left ventricular branches, supplying, as I said, the septal branches, supplying the septum, and the inferior wall by posterior left ventricular branches. This is the common distribution of the coronary arteries. So that was one portion. The second portion is, can we do some mathematics about the wall motion abnormalities? And that is something which is very important, that today there is some numerical values given to wall motions. If we have a normal, and what we call normal is when there is a diastolic thickness of maybe 1 centimeter, The systolic thickness increases by 50% and becomes more than 1.5 centimeter. Like this is diastolic, this is systolic, more than 1.5 centimeter. This becomes normal, and we give certain numbers to that. Hypokinesis is when the movement is less and thickening is less, and we although call kinesis, but this is basically represented in terms of change in systolic thickness. So from the diastolic thickness of 1 centimeter, it would become 1.2 to 1.5. That means 20% to 50% thickening of the myocardium segment in systole is hypokinetic. It's not normal. It is less than normal, but it is still there. Akinesis is when the thickening is less than 20%, 10 or 20%. Dyskinesis is, this means opposite. The movement or thickening is not there. That means instead of thickening, the thickness in diastole actually reduces. And this is because of the fact that when the systolic happens, the pressure increases, and this pressure pushes that segment out and also thins out that segment because there is no contractility in that segment. And last one is aneurysm. Aneurysm is when there is an outpouching even in diastole. There's so much outpouching that the diastolic pressure also makes the segment go out. That is what is called as aneurysm. This is because nothing here is muscle. Everything is fibrous tissue. The amount of muscle reduces as we go down. Normal has the maximum, almost more than 90% of the muscle here is alive. Hypokinesis more than 80%, this more than 70%. And dyskinesis is, akinesis and dyskinesis is variable, less than 50% muscle may be thickening alive here. And dyskinesis is almost certain that there is no significant surviving tissue. And aneurysm is no muscle, only fibrous tissue. And we can give certain score out of it in an increasing order. As the wall motion defect increases, so the number of the score given also increases. And if we have 16 scores, 16 segments, each segment is given a score. So if every segment is normal, this would be a cumulative score of 16, right? And we divide it by number of segments scored. That means 16 divided by 16 would be 1. So if we have a score index of 1, that means it is normal. However, as we evaluate the segments and we rank the numerical value for each segment as 1, 2. So, example, there are 4 segments which are akinetic, which would mean 3 times 4 is 12. Rest of the segments are okay. That means 12 segments are 12. So, this would become 24 divided by 16, which would become a index of 1.5, which is high. So anything above 1.5 is very significant of LV dysfunction and is a poor prognostic sign. So whenever we do an assessment of a wall motion abnormality, we have to have these 4 points in our mind. I know tomorrow you should not be able to do that, but you have to practice, practice, and practice to give these 5 answers whenever you look at wall motion abnormalities. First, whether there is a segment which is less contractile as compared to the rest of the segments, so presence or absence of wall motion abnormality. Second, how severe, as I said, is it akinetic, hypokinetic, dyskinetic? Whether there is scarring. Scarring is fibrotic tissue, and I'll show you some examples. Fibrosis means no surviving muscle, unlikely by any revascularization methods to improve. So it's a poor prognostic sign. We should be able to give which vessel is involved. Also, because we have an understanding of LAD territory, circumflex territory, RCA territory, we should be able to judiciously, intelligently say whether it is one vessel territory, two vessel territory, or multiple vessel territory. Because as we know, multiple vessels, poor prognostic, larger the vessel territory, poor prognosis, scarring, and larger severity is a poor prognostic sign. So let's go to some live examples. I know you are not able to be able to speak. If it was there in live performance, I would possibly have asked you a question. So this is a para-sternal long axis view, and you'll have to accede and agree to whatever I am speaking. As I said, this is the mitral valve. The closer segment of the anterior septum to the mitral valve is basal anterior septum, and the lateral portion is the distal or mid anterior septum. Because the right ventricular outflow tract is completing here, there is no distal or apical anterior septum. It is only the mid and the basal anterior septum. If you look at the systolic thickening, this area is contracting pretty well. The systolic thickness is increasing. Then for that, you have to tune your eyes with the cardiac cycle. So there is a good contractility and a good movement. But if you look at the opposite side, this is the posterior wall. The papillary muscle is not seen during the systole, but this is the posterior wall, the basal portion and the mid portion. This is the chordae tendineae, and this is the papillary muscle head. So you cannot see any change in thickness. Rather, when the ventricle wall thickens, this goes outside and thins out. So this segment is dyskinetic. So there is a dyskinesia of posterior segment. Posterior segment is supplied by the left circumflex artery. And which portion of the left circumflex artery? Proximal or distal? I discussed it out. Lateral wall is proximal and posterior wall is distal. So at least the distal segment of the circumflex is definitely related to this infarction, right? Okay, change in gears. This is another example of the same patient in four-chamber view. In the four-chamber view, we can see the septal area, the basal septum, mid-septum, apical septum. You can see all these three segments contracting pretty well. You can see the endocardium that can move, see inside movement, thickening, increasing by 50%. These segments are okay. If you look at the opposite side, this is the lateral wall. There is movement here, but there is no contractility. You see, there is hardly any change. Rather, this thing moves, but this does not come in, does not contract. Whereas the apical segment is still showing some inward movement. So this is the LAD territory. As you go back to my initial description, this is the LAD territory. The tip of the apex is LAD, distal portion, contracts pretty well. This is the right coronary or PDA artery, which is contracting pretty well. Let's go to the two-chamber view. In the two-chamber view, this is the inferior wall. You can look at the inferior wall, it is contracting pretty well, right? Inferior wall is supplied by the distal portion of the right coronary artery, right? In posterior left ventricular branches. The basal as well as mid portion is contracting well, apex is well, and the anterior contraction is also okay. So the LAD segments seem to be okay, and the right coronary artery territory is okay. So what is important is only the lateral wall and the posterior wall, which means the circumflex. And because the lateral is involved, it means proximal circumflex artery is infarct related. Let's change a class here. This is again a parasternal long axis view showing the basal and mid anterior septum. The base, look at the posterior wall. The posterior segment seems very good. There is a good thickening, almost more than 50% during the systole. Basal as well as mid portion is normal. So the posterior segments are normal. That means circumflex in this particular patient is normal, right? But on the other hand, if you look at the anterior septum, this is not contracting as well as the posterior segment is. So this is less. And mind it, if we go back to our description of contractility, the contraction here is less than normal. And that is why this is hypokinesia, because our eyes do not see perceive the movement or thickening of less than 20%. That is why in akinesia, for a naked eye, it would be seeming as no thickening at all. And that is why it is called as akinesia. It's very difficult to measure the exact thickness changes, but if it is perceptible thickening, then it is hypokinesia. If there is no thickening perceptible, this is we call as akinesia. So here, basal anterior septum is hypokinetic. Mid anterior septum here, beyond this particular segment, this is basal, this area is basal, and this area is distal. You cannot see any perceptible thickening in the distal segment. Only the basal segment is hypokinetic. Mid anterior septum is akinetic, which means basal anterior septum, as I said, is supplied by the first septal branch, probably the first branch of the LAD. So this person is likely to have a proximal left anterior descending artery block. Not only the LAD, but in the proximal segment. The second part I am going to talk about wall motion normality is assessment of 3D motion. We have to understand whenever we're looking at the contractility, unfortunately, the ventricle is being cut in a particular direction. But the ventricle is a three-dimensional object. It is not only contracting, coming in and out, but also writhing. So you may have a change in the segments. And that is something which we have to be very clear about. It is that the heart is not only coming in and out, it is also rotating in its axis. So that is why if you look at this particular combination, look at this particular view. This is a parasternal long axis view. You look at the anterior septum, which is normal. But what is about the mid anterior septum? You would always say that this segment seems to be contracting less as compared to the septum, basal anterior septum, but is moving in, right? But if you focus very carefully, it is moving in, but it is not contracting. The thickness is hardly changing. And this is so very common when we have a hypercontractile basal anterior septum or adjacent septum. This is because we have movement but no thickening. And the reason for that is a pull effect. When the heart rate is high, when the contractility of adjacent segment because of compensatory hypercontractility is high, what it does, it pulls the adjacent segment along with it. And you falsely perceive movement as thickening and rank hypokinesia, akinesia in akinetic segment is hypokinetic. And this is underestimating the wall motion abnormalities. Same thing is reversed there. In this particular contractility, you will find the septum seemingly less contractile, but very commonly is left bundle branch block in left ventricular, right ventricular pacing. What happens is the septum actually contracts first, and there's a jerk which contributes to early contraction of the septum, and unfortunately, we rank as hypocontractile, but actually it is normal contractile at a different phase. That is why we see it as a false segment abnormality. And we have to be cautious, specifically if you have a pacemaker, left bundle branch block, and sometimes the WPW syndrome. Another important thing is to avoid errors is to look at the landmarks. So I would ask you guys, what is this view? This is a parasternal long axis view, right? Most of you would say this is the mid basal posterior wall, and this would be mid posterior wall, right? But go back to the anatomical landmarks which I mentioned. This is the papillary muscle. You see this posterior inferior papillary muscle? It does not arise from the posterior wall. So that means, although this seems to be the parasternal long axis view, but this is not the posterior segment. It is looking at the inferior segment. And many a times, if we're not cautious, we can make errors of judgment and make a single vessel disease a double vessel disease and vice versa. Same way here, if we look at this four-chamber view, we would rank this segment as a basal septum, right? Mid septum, apical septum, apical lateral, mid lateral, and basal lateral. You can see the papillary muscle head. But if you're not cautious, you be cautious about this thing. This is aortic valve opening. And if the aorta is opening, this is no longer a four-chamber view. This becomes a five-chamber view. Aorta is an anterior structure, and the septum portion, which is adjacent to the aorta, becomes anterior septum, not the septum. So this would be a territory supplied by the first septal branch of the LAD rather than the PDA. So this would become a judgmental error. Again, the same kind of mistakes you can do. Be very cautious in the two-chamber view not to be seeing the portion of the right ventricle. Otherwise, you're not looking at the inferior wall. You are looking at the septal portion, the posterior most septal portion, and you can make errors again. So let's look at this important case. So if I ask you guys, this is a four-chamber view. Do you agree? You'll have to agree because you don't have an option. I don't have a voting pad here. So this is the left ventricle, this is the left atrium, this is the right atrium, and this is the right ventricle. The basal septum is fine, mid septum is fine, apical septum is hypocontractile, apical lateral is normal, mid lateral is normal, and basal lateral is normal. You can also see the papillaries, right? So the wall motion is just hypokinesia of the apical septum. The ejection fraction by wall motion by visual analysis here would be good 45-50%, right? So the calculated ejection fraction here would be about 45%, right? Okay, let's look at a competitive different four-chamber view. This is also a four-chamber view. This is the left atrium, right ventricle, and the left ventricle. The basal septum is normal, mid septum is akinetic, apical septum is akinetic, apical lateral is akinetic, mid lateral is hypokinetic, basal lateral is okay. So there are two akinetic segments, one, two, three akinetic segments, and one hypokinetic segment. So this means out of the six segments scored here, there are four segments which are dysfunctional as compared to only two segments which may be normal. And what would be the ejection fraction with this large area? It would be hardly 25%, right? You'll have to only say yes. In your mind, what I am saying is what is the perception, and this would be around 20% ejection fraction. Can you imagine these two four-chamber views belong to the same individual, and the images had been taken just 5 seconds apart? Can you imagine both these four-chamber view belong to the same patient taken 5 seconds apart, just for the sake of description? And the reason for that is this we call as foreshortened view, because you can see there is a little bit of tilt here, although the papillary muscles are seen, and the reason for that is seen here. This is the two-chamber view. The apex is here somewhere. Whereas if you follow my pointer, this is the long axis of the left ventricle, and the apex would be somewhere here, right? But the transducer is positioned here, and it is containing the left ventricle in this particular direction. And it is not looking at the apex in this particular view, in the left-sided view. Whereas it was a correction made when the transducer moved further out and down, and the true apex was normal. Mr. Mahesh Karadi, you'll have to mute yourself, please. Dr. Mahesh, you'll have to mute, please. Dr. Mahesh's mic is on. So this is what it is. And the major problem is, if you look at my chest here, in my view, what you do is you usually start with a parasternal axis view, and then we move out to the apex. And as soon as we see a four-chamber view, we say, yes, we have had a four-chamber view, and we stop there. This is wrong. You should keep on out and down till the time you lose the heart, and then you slightly come in and look at the four chamber view. That would be right, because we have to look at the outermost, lateralmost portion of the left ventricle, which is the apex beat. And this is only possible when we keep on moving out and down till we lose, and then we come in and then look at the apex. We would not commit such kind of a mistake. So this is the effect of foreshortening. You can easily make a very poor ventricle 20% to almost normal ventricle, and this kind of a discrepancy is going to be there. So you have to be training yourself, understanding what you're looking at, and then taking call. Again, if you look at this particular parasternal long axis view, what is your comment upon the anterior septum? Any contractility? Okay. Look at this particular patient, the lateral wall apex. What is your contractility? Normal, hypokinetic? You can make any kind of judgments. Until and unless you see the endocardium, please refrain yourself from commenting. Because until unless the endocardium is seen, you cannot judge the thickening. You can always perceive some movement, if at all. So this is better to say not analyzable. Go to some other views, short axis views, parasternal views to get some better windows. An improper window, 5 to 10% of people, specifically very obese or very thin, would have such kind of a people windows, and which is unanalyzable. You can use contrast echo in these people and get a better results rather than making errors. So it's a big courage to report could not be visualized, and have that courage. At least you are not committing an error in disfavor of the patient and causing a problem. You can always have a better option doing a contrast echo or transesophageal to get a better outcomes. Before I say anything else about the global ventricular function, I want to warn you guys one very important thing. When a person presents to us in emergency with acute coronary syndrome, chest pain, and we are suspecting an acute coronary syndrome, we look at three things: the symptoms of chest pain, the biomarkers, and ECG changes. These are the things which diagnose acute coronary syndrome. Unfortunately, echo can guide a presence of likelihood, but it cannot diagnose acute coronary syndrome. You can diagnose ischemia while doing a stress test by a stress echocardiogram. But when a person presents to you with chest pain, you cannot be certain this wall motion abnormality is now or past. That is why we have to depend on the ECG, chest pain, and biomarkers for the diagnosis of acute MI and treat accordingly. A word about global left ventricular function. We have talked about regional, which is so very important for the distinguishing of regional wall motion abnormality. It's important for diagnosis of ischemic versus non-ischemic heart failure. But I would say what not to do about global. Unfortunately, the ventricle is a three-dimensional structure. And if we commonly do the Ticolo's method, the actual dimension measured would be like this, and the actual diameter would be like this. So this would be a big fallacy. Moreover, you are detecting three-dimensional structure with a single dimension. So I would always urge you guys never ever do Ticolo's method for volumetric assessments. The best way is Simpson's method, where you go to four-chamber and two-chamber views, biplanar view, and you trace the endocardium here in the diastole and in systole. What happens is the machine gives you automatic calculation of the volume by disc methods. It breaks the whole length of the left ventricle into about 20 discs, summates the volumes, and give you a assessment of end diastolic as well as systolic volume. And this is the best way. The biplanar Simpson's method is the best way to detect the volumes, the diastolic and systolic. The difference of diastolic and systolic volume is the stroke volume. That means when the ventricle expands in diastole and then it contracts in systole, what volume it has pumped into the aorta is the stroke volume. It's the difference between diastole and systole. And the fraction of the systolic volume to the diastolic volume is ejection fraction. We have to learn doing that by Simpson's methods. And this is something which is painstaking. More often than not, once you train your eyes, you will be able to guide yourself that, yes, if you look at the ventricle, just I told you about the previous ejection fractions, you can very precisely get ejection fraction estimated in your mind, which we call as eyeballing. So for a good eyeballing, you should have at least 200 monitored, calculated ejection fraction supported by your estimations. So this is what I was talking to you about. Experienced echocardiographers usually do not do ejection fraction calculations by volume assessments. They can just see and tell you what almost within 5% the ejection fraction is going to be. For beginners and learners, you always have to do biplane Simpson methods to give you a good ejection fraction. Three dimension is the best way, most best correlated with MRI is the gold standard for ejection fractions and volumes. However, not all of us are tuned to do ejection fraction calculation by 3D echoes. It's important to do calculation of ejection fraction. Why? Because today, as I was mentioning, the heart failure is distinguished between heart failure with reduced ejection fraction, heart failure with normal ejection fraction or preserved ejection fraction, and heart failure with mid-range ejection fraction. So people with heart failure with reduced ejection fraction, that means ejection fraction less than 40, the lower the ejection fraction, worse the outcome. And less than 40%, at least we have four class 1 indications for medications which have to be given. ICD indication for ejection fraction less than 35. CRTD indication for injection fraction less than 35. All of those things are directed towards a low ejection fraction therapies. Preserved ejection fraction, we do not have, unfortunately, a standardized treatment available, except for SGLT2 inhibitors, which are there. I think this forum is not to describe those things right now, but probably in question and answer, I can go ahead. Uh, the last thing I'm going to talk about is the new advance in the strain rate. I do not know how many of you are doing it. Probably Dr. Rakesh Gupta would find a new venue to discuss the strain rate and imaging in coronary artery disease. But what is important is to understand that the myocardium is like a muscle sheet, and the muscle fibers are not just the circular one, but they are longitudinal fibers also. And there are oblique fibers also, which would mean whenever the ventricle muscle contracts, it would not only reduce the circumference, when we call it as circumferential contraction, but it would be longitudinal also, and it would be a writhing movement. So the writhing movement says the ventricle apex and the base are moving in opposite directions, like this, opposite direction. And this is why we have to be very cautious when we look at the left ventricular complex motions. We are not only the circumferential, longitudinal, radial, and the distortion, which we have to be look at twist. So this is something which has to be looked at. The simple principle of speckle tracking is that today's machines, they can recognize the pattern of the myocardium just like fingerprinting. The finger has all those fingerprints where those small lines have uniquity for every person. So these machines today actually identify the relationships of these speckles, dots in the myocardium, and they can track those speckles in the different phases of myocardial motion. So in systole, the normal thing would be the contraction would be systolic. the longitudinal long axis would also reduce. So if we look at the global longitudinal axis movements, the machines have a way to track these small speckles in relative motions. And they can mention the distance between those speckles is reducing or increasing. So normally when the ventricle is contracting, the length of the left ventricle reduces and the distance between these speckles would reduce. So this is why if we look at the change in the length of the left ventricular walls, it would reduce in systole, and normally the reduction is up to 20%. That means in systole, the length of the left ventricle would be minus 20% of what it was in diastole. So the global longitudinal strain is minus 20. Sorry. The global longitudinal strain would be minus 20. That means the length of the left ventricle has reduced by minus 20% in systole. Okay. Anything less than that, that means if the length of the left ventricle reduces 15%, it is global longitudinal strain minus 15, which is
अभी साइड में
less.
फोन
It's
चलेगा
significant.
फिर ये
It is
चलेगा
significant. Dr. Endu Pathak, it is significant of LV, emergent LV systolic dysfunction, early LV systolic dysfunction. So this speckle tracking is important to actually analyze the early onset left ventricular systolic dysfunction before the ejection fraction drops. But what is important is that if we plot this four-chamber view, the machine can track all these speckles and break it segment by segment. The yellow is the basal septum, light blue is the mid septum, green is the apical septum, and you can see all these segments can be plotted in diastole and systole in this M-mode type of a curve or the volumetric type of a curve. We can come out with a lot of calculations. Each, say for example, this purple line is here, and this can calculate the regional ejection fraction. This is the diastolic volume, and this is the systolic volume. They can calculate the regional ejection fractions. It can also give you global longitudinal strain. It can also give you the longitudinal strain in the M-mode pattern. And you can have a lot of understanding of how these segments are moving relative to each other with cardiac cycle. The same thing as I told you about the bullseye plot can be drawn. As you see, this is the 17th segment. All of them can be drawn into various segmental uh, um, uh, longitudinal strains, and a global longitudinal strain can be estimated total is coming out to be minus 14. As I said, normal should have been minus 20. This is too low. So this is a significant LV systolic dysfunction. So most of the vendors now have uniformity, and this is reproducible. The global longitudinal strain is there to stay. Circumferential strain is still experimental, and I would not go into the detail of it. Radial strain is the thickening. As the systole happens, the thickness of the segments increases, right? So this strain is positive. That means during systole, the thickness has increased rather than decreasing. So this would be a positive value. Rest of the strains are negative values. Last but not the least, let me give you an example. This is a case where we were doing a dovitamin stress echo. This is a four-chamber view, two-chamber view, apical long axis view, and parietal long axis view. Basal septum, mid septum, apical lateral, mid lateral, basal inferior, mid inferior, apical inferior, and the three anterior walls. These would be basal anterior septum, mid anterior septum, basal posterior, and mid posterior. So all 16 segments. We look at the longitudinal strain. What would happen is in this particular view, sorry, you can say that everything seems to be contracting well. I don't see any wall motion abnormality. What is not evident to the naked eye, if we put a bullseye plot, it shows that apical segments are less contractile. This is -3, -9, -8, whereas basal segments are -15. So what we are missing out on the visual assessment of the wall motion abnormality, the apical septum and apical lateral were less contractile as the basal segments, as was evident in this uh, global longitudinal strain derived bullseye plot. So that is where the GLS can actually help in borderline wall motion abnormalities and give you a good outcome. Thank you. Thank you for your attention. I think now I'll stop sharing my slides. If you have questions, I'm here to try to answer those.
Dr. Sanjay, good, absolute clear-cut perception, clear-cut delivery. Now, my request, any questions, they can raise their hand so that we can answer those questions. I saw that first somebody had raised their hands earlier. It was, yeah, one person has raised the hand. Dr. Naveen, please go ahead. Naveen, anybody else by the time Naveen is trying to connect? Dr. Shripad Kore, go ahead,
Sir,
Dr.
good evening. Sir, how to identify scar myocardium on echocardiogram fetus?
Very good question. I tried to put a couple of cases there. Scar is fibrous tissue, right? Whereas muscle is a lot of fluid, water. So there would be water and fibrous tissue mixed in, connective tissue mixed in muscle, whereas scar is just pure and simple fibrous tissue and less water. So whenever we have a scar, it would be more of a fibrous tissue, which would be white, and the muscle wall or the segment would be apparent as a white, thinned out segment, whereas the muscle would be seen as a gray. Uh, I think you have to see those muscle segments very clearly. Normal
Okay.
segments are something which I'll try to show you that example again. I'll try to show that example again. I think I did. Are you able to see the slides again?
Yes, sir.
So this is something which I showed you to begin with. Oh, I'm already into the. So this is what it is. You see this fibrous tissue here? This is the muscular tissue, right? And here you can't see any muscular tissue. This is all scar, right? If I
Yes, sir.
give you uh, another example, I'll show you this.
Sir, one of the parasternal long axis view, there is a fibrous white band. Was
Here,
yes, sir. Is it a scar myocardium?
this is epicardium, right? So
Yes, sir.
the fibrous tissue would be like epicardium. This is normal tissue, unfortunately not yet scarred, but this is not a typical scar area. What would happen is in the scar, the muscle area would appear like this. I show you an example. You know, that was a little calcified area. Okay, where this one. See this? This is the scar.
Yes, sir.
This area is scar. This is muscle. this is scar. Okay?
Yes,
Rather,
thank you, sir.
it's calcified specs also, which is causing poor visualization of the endocardium in this particular place. All right?
Yes, sir. Thank you, sir.
Dr. Jeel Balas.
Sir, good evening, sir.
Good evening.
Sir, how to quantify ejection fraction on eyeballing?
Aha. So you'll have to do as much of efforts as I did to lose all my hair, you know? And same thing with Dr. Rakesh Gupta. So you can, eyeballing is something which you have to train yourself. The best way is do the mathematical calculation, the biplane ejection fraction calculation by Simpson's method. And then, okay, this is where 25% looks like. This is where it looks like. But what is important for us, we submit all the views. When we do a parasternal long axis view, we do a short axis view, we do apical long, a four chamber and two chamber view. We have a complete assessment of wall motion abnormalities, volumes, excursion of the walls, and the kind of comparison of our ancestrally how much ejection fraction would be. This is the experience. And that is why I said, for a beginner, don't go for eyeballing. Train your eyes that, okay, I saw this kind of movement, this kind of excursion, and if we calculated the ejection fraction, it was around 25%, 25 to 30%. Many a times you can train yourself by looking at many echoes in general under the guidance of a trained echocardiographer and understanding that, okay, this much excursion, ejection fraction would be around 40, 35 to 45, that is almost plus minus 5. So please don't jump to eyeballing immediately. It takes a lot of experience and time.
Great, Sanjay.
Thank you,
Perfect
sir.
answer. Perfect answer. And possibly, like, I feel like eyeballing, I, artificial intelligence at one day will give you ejection fraction straightforward. Maybe that day will come. You don't need an eyeballing. AI will give you ejection fractions. Let's move on to Dr. Kasim. Dr. Kasim, please go ahead.
Thank you, sir. Sir, in case of arrhythmia like atrial fibrillation, how we can calculate the ejection fraction accurately?
Very good. So ejection fraction, atrial fibrillation is a miss any which ways. Whatever you do, there is going to be beat to beat variation in ejection fraction. Why? Because the length of diastole determines the end diastolic volume. So if there is a fast beating, the volumes in the diastole are going to be small. If there is a slow beating, the volume would be, the diastole would be longer and the volumes would be higher. So ejection fraction would change from beat to beat in atrial fibrillation. Absolutely right. So as a matter of principle, whenever we are talking about atrial fibrillation, we have three methodologies which we use. When we look at gradients, when we look at everything, we look at a averaging out of 5, in research portfolios 10 beats. In actual day-to-day clinical practice, 5 beats. If the rate is relatively okay, relatively stable, then up to 2 to 3 beats, 3 beats average could be taken. For ejection fraction, we choose the beat of a longer diastole or longer RR interval, because that is where the Frank-Starling law is the right one. And prefer to use the same diastolic length when we do a 4-chamber and 2-chamber approximation. So that is an important read. I would say at least 3 cycles estimation of end diastolic and systolic volumes. Each cycle would be the ideal way to go.
I hope that is answered very well, like exactly what everybody does in a clinical practice. And that's how we do it. My answer to submission is look at a heart rate of between 70 to 80, Do your 4-chamber, look at a heart rate of 70 to 80. Do your 2-chamber, that'll be a true ejection fraction. So otherwise, if you have a tachycardia, you'll have a low ejection fraction for sure. That'll be there. Dr. Anil Chaudhary, please go ahead. Your turn.
In Simpson method, images are too much blurred most of the times. So, how can we clarify the images? And
There is a
particularly in systole, it is most commonly blurred, sir.
all right. So I would say three things here again. We very commonly use the terminology garbage in is garbage out. So what is happening is until unless you see 70% or more of the endocardium, please do not use that image for calculation of any volumes. And that is diastole as well as systole. The second thing I would say is what needs to be trained is your hands and your eyes. The hands should not shake during diastole and systole. This needs huge bit of experience, how to change pressure so that the heart movement and chest movement does not change your angle of interrogation from a person who is showing papillary muscle in diastole and no papillary muscle in systole. So the aim is to actually have a good diastolic and systolic view. That is a big art. So that is where the learning is. Initially, you would have such kind of problems that the frame in diastole comes good, in systole it vanishes off. That means you have to make more effort to get both the frames into a systole. Be patient. Rome was not built in a day. You have to look at it, keep on doing it till the time both frames come into the same view. The last one is important that, as I said, 5 to 10% of people would have a poor window. Very skinny people, when the indrawing of the intercostal spaces make a huge bit of air gap between the transducer and your skin, you would have a poor windows. In those situations, probably nothing can be done. You would have to resort to some other window, probably make the person stretch the arm more so that the intercostal spaces go away, and do something, some jugglery to make sure the imaging is better. But the thing is that you have to do all those three things. One, that until 70% of myocardium is seen, reject it. Second, train your hands and eyes not to shake before you actually have a good organization. And also learn, this is a big learning, this fine tuning. Just I said, holding a pen and scribbling just like a child does on a piece of paper is easy. But writing meaningful A's, B's, and C's, and then writing a cursive line, which is the state of the art writing, is an art. And to make a child, an infant, learn a cursive writing would take years of practice. So I think it's a fine tuning. You have to learn it. This is what experience comes. You put the transducer on the chest, and you would know what pressure to apply, how to actually organize your hand movements. Finally, fine movements to adjust to the respiratory rates and the cardiac movements is what the art is.
Okay,
Perfect,
sir.
Sanjay.
Thank you.
Perfect. Thank you, Sanjay. Let's move on to Dr. Naveen. Naveen, anything you want to ask, please go ahead, Naveen.
Thank you for the presentation, sir. So I have a doubt. In the presence of a bundle branch block, how do we assess for the regional wall motion abnormalities? For example, LBBB and LAD territory.
Okay. So, good question. The answer to that question is that I'm not talking about bundle branch block. I'm talking about left bundle branch block. Right bundle branch block does not alter the left ventricular contractility. Left bundle branch block actually leads to the, say for example, these are this is the septum and this is the lateral wall of the left ventricle. What happens is the right ventricular wall the septum is getting stimulated first. And instead of the lateral wall getting stimulated simultaneously, the septum actually excites, and then the current moves to the lateral wall through a circuitous route, which takes a few milliseconds more. So the septum contracts earlier. By the time the current reaches the lateral wall or the major of the segments, the septum has already contracted. By the time this contracts, the lateral wall moves out. So because the fact the most of the ventricle is moving at the particular phase, you feel the septum is not contracting, it's actually moving out. So this jerky movement, paradoxical movement of the septum is what is a hallmark of left frontal branch block. But as I said, if you are focused on systolic thickening, as soon as the R wave comes and the increase in the septal thickness, you would find that the septal thickness is maintained despite the fact that there is a dyssynchrony in the wall motion. And that is what you have to train your eyes. Apex lateral wall does not change course. It is only the septum. Mind it, also, as I said, the septum does not obey the distribution of the LED territory. And that is something which you have to be very cautious about. It does not mean it is a left anterior descending artery territory. It's only the septum, which may be the posterior as well as anterior septum showing a dysynchronous movement.
Thank you, sir.
Anybody else have some questions? Janvi Jevan, you were the last one to ask this question. And you were the first one, rather, when you raised your hands. Go ahead, Janvi.
Thank you, sir. It was nice to hear. I want to ask about, sir, can you, sir, can revise how to scoring of that thickness and all these things, in short, scoring system for that thickness during systole.
So, as I said, there are 16 segments which I use, right? Each segment, when you are focusing on one segment, basal anterior septum, for example, there would be a diastolic thickening. And when the systole happens, the thickness increases. Diastole, systole, diastole, systole. So normal thickness is that in diastole, if the thickness was 1 centimeter of that particular segment, the systolic thickness would become 1.5 centimeters or more. That means the systolic thickening would be 50% or more of the diastolic thickness, right? So this is normal. And we rank this as score number 1. One segment, one score. If this is less than 50%, but more than 20%, this is hypokinesia. If it is less than 20% of diastolic thickness, it is akinesia. But as I was mentioning, that it's very difficult to measure the thicknesses. How we practically look at the hypokinesia, akinesia, and dyskinesia is that you have a normal segment, just like most of the examples which I showed you. One segment was contracting well, and the next segment adjoining to that was not contracting as well. This was hypokinetic because I could see that it is contracting. There was change in diastolic thickness during systole, but it was not as good as the adjoining segment. This is hypokinetic. If I see no change, perceptible change in thickness, this is akinesia. If I see there is a paradoxical movement and thinning of that particular segment, this is dyskinesia. And if I see a segment which is outpouched, ballooned out in diastole as well, as the first case I showed you, there was a ballooned out segment in the diastole also. This is aneurysm. So as the wall motion abnormality increases in this order, we increase the number of given to them. So normal would be 1, hypokinesia would be 2, akinesia would be 3, dyskinesia would be 4, and aneurysm would be 5. So the higher the number, worse is the chance of that segment having surviving muscle and recovery, and poor is the prognosis. And cumulatively in 16 segments, if we look at, there are 5 hypokinetic segments or 2 akinetic segments, it's almost becomes the same. So that is a uniformity of a calculation of wall motion score index, which is important to be understood. Anything above 1.3 is a poor prognostic marker. And that's how we can use in our clinical day-to-day terms.
Thank you, sir. But 1.3, not.
Yeah,
not.
okay. So if you have 16 segments, right? And I give you an example. There are 4 segments which are akinetic, for example, right? 4 segments which are akinetic means each segment would have a score of 3. Okay. So the 4 segments having 3 each would be 12, right? How many segments are remaining? 12. There are 12 segments which are remaining. Out of 16, 4 segments were akinetic, rest were normal. So how many segments? 12 segments were normal. We get it?
Yes.
So if the 12 segments were normal, each segment has score of 1. So total score would be 12. So if we look at the 16 segments, this would be 12 plus 12 means 24 is the score, divided by total number of segments which were calculated was 16, which would become 3 by 2 is 1.5. Right? The score index would be 24, which is the total score divided by total number of segments, which is 16. Are you understanding?
Yes.
1.5.
So this would 24 divided by 16, which would become 1.5.
Yes.
Okay. So that is anything above 1.3 is poor prognostic sign. So 1.5 is a poor prognostic. That means almost 1/4 of the myocardium is gone. Ejection for in this person also, ejection fraction expectedly would be around 30, 25, 30, 35, not more than 35.
Yes, I got it. Thank you.
All right, guys. Any other questions? So there's no more question. Let me pay thanks to Dr. Sanjay Mittal. Exclusive, excellent talk. I hope we are able to clear your doubts about systolic function. And let's take a break for about 10 to 15 minutes before we get on to diastole today. So
Thank you, Doctor.
Sanjay. Thank you very much. And we'll request everybody to join back.
Thank you, sir. Thank you.
Minutes
Thank you, sir.
for this
Thank you. Bye-bye.
Thank you very much, Sanjay, once again. And we'll leave to join back in 15 minutes time.